Nigeria recorded the first case of Ebola virus disease on the 20th of July 2014. For the first time, the disease escaped isolated rural villages where it first appeared in Guinea and spread across borders to Sierra Leone, Liberia, Senegal, and Nigeria.
At the time, we knew nothing about Ebola. We were just hearing Ebola in Liberia, Ebola in Sierra Leone until that day. But even at that, we didn't get to know until 4 days later.
In Nigeria, public health teams mobilized and put minds together based on many years of experience working on various infectious diseases. The Nigeria Field Epidemiology and Laboratory Training Program is a 2-year program in applied epidemiology established in 2008 to train leaders in applied epidemiology and public health laboratory practice, provide epidemiology services to federal, state, and local government health authorities in Nigeria, strengthen public health and veterinary surveillance systems, and forge linkage between public health and veterinary epidemiology. It also sets out to strengthen laboratory participation in surveillance and field participation. The emphasis is on problem-solving issues of public health concerns. The first cohort of 13 FELTP residents who began their training on the 20th of October 2008 graduated in December 2010. The program has so far enrolled a total of 262 residents since. In collaboration with the CDC Nigeria, USAID, Federal Ministry of Health, Federal Ministry of Agriculture and Rural Development, University of Ibadan, and Ahmadu Bello University's Zaria, FELTP has responded to outbreaks of other diseases like My Pikin, Lassa fever, lead poisoning, cholera, measles, yellow fever, dengue fever, meningitis, and more. FELTP hosted the first Ebola Rapid Response Coordination meeting on the 23rd of July 2014 to develop terms of reference for a plan of action for the outbreak. Residents, faculty, and graduates of the FELTP were keenly involved in the investigation and response of the outbreak, coordinated through the Emergency Operations Center in Lagos. A total of 100 residents and graduates participated in response supported by the WHO, CDC, MSF, UNICEF, and the Federal Ministry of Health. The Ebola team set out to do surveillance and contact tracing in the 3 affected states of Lagos, Rivers, and Enugu.
I actually volunteered in Lagos State during the Ebola outbreak. I work with the Lagos State government, and I was seconded to the Ebola Operations Center, and I happened to be placed in surveillance, and surveillance was mainly coordinated by FELTP. Now I had a lot of exposure. It was the first time I was involved in an outbreak investigation, and I was involved in contact listing, contact tracing, and I learned a lot of skills during this time, following up people and trying to get the right information. But I was impressed by the FELTP graduates and residents I worked with.
All the stakeholders came together and they formed the EOC, and it involved multidisciplinary teams. And of course, there was the epidemiology team, and part of the epidemiology team was the contact tracing team, and that was where most of us from FELTP were involved. We were involved in registering the contacts, following up all those who had contact with that primary case, and then of course identifying as early as possible those who eventually came down with the disease and getting them as quickly as possible to isolation center to prevent possible spread of the disease in the state.
Professor Adebola Olayinka, Laboratory Resident Advisor FELTP, who supported the response to the Ebola outbreak in Kenema District in Sierra Leone, supervised case management and the Emergency Operations Center in Lagos.
Case management team comprised of 5 subcommittees. One of the committees was the psychosocial committee, and that was important because they needed, apart from the fact that the patients were sick with Ebola, a lot of them were psychologically affected, either the depression of why me, why should I have Ebola and all those things. So you needed a psychological team to manage that psychological aspect. The social aspect, because there were needs. People were picked up with almost nothing and taken to a ward. And they needed clothes, they needed basic things, toiletries and all that. So the social aspect supported that social need. So we had them as a joint group called the psychosocial team.
Residents and graduates of the FELTP championed the conduct of 3 operational researches in Lagos State, which provided information that guided the interventions to control the outbreak.
3 researches were conducted during the outbreak in Lagos by the Operational Research Unit of the Ebola EOC. The first one was on public assessment of public knowledge, perception, and source of information on Ebola virus disease. The second was assessment of the level of preparedness of healthcare workers.
There was so much confusion and panic in the air. It's an outbreak we've never experienced before. So there was so much on guesswork and fear. Fear was actually palpable in the communities across the nation, and you could see people literally consuming salt with water, and people were actually behaving below the knowledge they have. So we thought objectively we actually need to assess what the community know, what their attitude towards this outbreak is, and what are they actually doing. And why did we do this? Number one, to have an objective documentation of what is going on. And we didn't restrict that to the communities, especially in Lagos State, where we had it initially before we had another exportation to Rivers State.
Nigeria, being one of the 3 countries still fighting the polio epidemic, it has set up strong polio surveillance systems supported by the Polio Emergency Operations Center. When the Ebola outbreak occurred, it was crucial that Nigeria utilize the same systems to enhance surveillance. The well-established surveillance systems, rooted at the grassroots, was a major tool used for coordination and surveillance during the Ebola outbreak.
When we had an outbreak of Ebola in July 2014, because the program already had a pool of skilled personnel, we deployed them quickly to respond to the outbreak of Ebola. One important aspect I would like to talk about is, or I would like to mention, is the issue of contact tracing. Contact tracing is very vital in the control of highly communicable diseases like Ebola. And you don't joke with it, you have to use skilled personnel for it. We use trained epidemiologists that know that we have to stop the transmission of this disease.
A key factor in the speed of the response was data management, which was managed by Mr. Tom Abba, supported by the WHO, CDC, eHealth, and other partners to ensure that the data quality and completeness of cases and contacts was excellent. Tom coordinated the development of smartphone-based platform to ensure that the case investigation, clinical, including lab data and epidemiological data, was captured and updated regularly. Contact tracing teams were also assigned Android-based phones that they used to register and monitor all contacts. Contacts that developed symptoms were automatically triggered messages and alerts to the team, as well as the case management team for immediate swift action.
When we got on board, it was difficult for people to actually get data in, because everybody was going out with the forms. They fill out the forms through the traffic and all that to get the forms back to the EOC for reporting. But then we had to think about ways to create a system so that they can send this information almost real time.
I think the presence of FELTP allowed Nigeria to really do marvelous work in terms of how Ebola response should be. One of the cardinal points in Ebola response is effective contact tracing. Anybody who comes into contact with a symptomatic Ebola case should be followed up for 21 days to detect Ebola symptoms as early as possible and remove them from the community. That was the difference between the three other affected countries in Nigeria. FELTP, working with WHO and the government, had a robust contact tracing team that ensured all the contacts were identified and were followed up every day and reported to the EOC every day.
When we were starting in FELTP, we knew we were building a high caliber workforce that is going to respond to epidemics, that are capable of data management, surveillance, evaluation, and issues like that. But we never knew that we were doing that one day we will have an unusual epidemic in our hand. Nigeria FELTP rose to the occasion in that if you look at those who responded, residents from Nigerian FELTP, residents and graduates, formed the majority of those who responded to this outbreak. The difference between Nigeria and countries like Guinea, Liberia and Sierra Leone is because we have the workforce. Though we were keeping the workforce for the usual epidemic outbreaks within the country, not knowing that an unusual one will come and we will still need the same workforce. So we deploy them and they form the majority of the workforce that we deployed. Our response was swift. Our response was very, very successful.
For the first time, Ebola virus disease challenged world public health systems, exposing gaps in emergency response strategies. As world leaders and public health specialists scrambled to control the outbreak in West Africa, one country, Nigeria, was successful in controlling the Ebola outbreak. Though WHO recorded a total of 23,729 cases and 9,604 deaths in West Africa as of the 22nd of February 2015, Nigeria, on the other hand, recorded 20 cases and 8 deaths and managed to contain the outbreak in the shortest period with no further cases. On the 20th of October 2014, Nigeria was declared free of Ebola.
My personal experience is everything boils down to a miracle, because I was positive, even when I knew I was faced with death. But at that time, I was positive about my situation. Because I was saying there was no way I'm going to die. I was having the symptoms. I have every of the symptoms. Well, they did a marvelous job. Because in fact, that was what encouraged me to allow the government to come and take me.
Nigeria's success was made possible by a skilled public health workforce, many of whom were products of Nigeria FELTP. Right now, it's mostly funded by foreign donor partners, but for long-term sustainability, the support of the Nigerian government would be welcome. The lives of millions of Nigerians depends on it.